Welcome to Health in Today's Woman. I'm your host, Dr. Kelly Williams. As always, this show was designed to help women become champions of their own health care. Tonight we're going to take on a topic that has been very important both to me and to my practice, and that is the whole idea of infertility. Now, infertility or difficulty having babies can be a very difficult situation for many women as well as men. Thanks to new technologies, though, we are actually able to take patients who were once told they could not conceive and allow them to be parents. To help me better understand these technologies and these opportunities, I've invited Dr. Glen Weitzman, a reproductive endocrinology infertility specialist at Nashville Fertility Centers here in Nashville. So Glen, I want to start by saying thank you for being willing to be here.
Thanks for having me, Kelly.
And I want to start off just kind of where the patients start off with me. Patients oftentimes want to know, how do I know if I'm going to have infertility issues? And how long do I wait before really starting to find some, seek out care for those problems?
Well, the standard definition of infertility is a year of trying without conceiving.
Okay.
And for most people that applies, that they need to try for about a year, and if they are not successful, then to seek consultation with their physician, usually their obstetrician gynecologist. Now, as of late, because how much age has to do with the process, how important it is, we're now telling patients that if the woman's over 35 and has tried for 6 months and is not conceived, it's a good time then to consult with her doctor.
And one of the things I think is so important, and I tell this oftentimes to my patients, is this whole idea of we're not trying to torture you by making you wait a year. We want you to wait a year because so many people get pregnant in that first year that we don't have to do any kind of evaluation. Is that correct?
85% of couples who try will conceive within the first year. And statistically, if those people who do not conceive after a year try on their own for another year, half of those will conceive during that second year.
Yeah, and that's kind of what I tell people. There's only about 7% of patients that do have this problem that really need to be addressed. Is that about right?
Yeah, it's about right.
Now, I want to talk to you a little bit about, too, because once they make the decision, okay, now somebody has told me that we are possibly going to have a problem with infertility, what kind of workup do these patients go through as the basic workup in the infertile couple?
Yeah, well, the basic evaluation includes a sperm count, which is very basic. Typically, we do some hormone studies on the woman, and we'll often do an X-ray of the woman's uterus and her fallopian tubes called a hysterosalpingogram or an HSG. And that's a very basic, solid beginning infertility evaluation.
And you mentioned an HSG or hysterosalpingogram. We have some pictures here because I think it's so interesting to look at. And you can see on the screen now that we have a picture. Just explains this a little bit. It looks like the uterus is completely filled, and if you can see, you'll see some kind of whiffs of what is dye. It looks like smoke coming out of the tubes. That shows that those tubes are open. And then we'll go to the second picture. Tell us a little about this one. This is a little bit interesting one.
Well, this is actually the before picture. Before that first picture that you saw, this is a divided uterus, a uterus with a septum in it, and you can see that the cavity, it's like little tubes coming off to the left and the right, tubular structures. The cavity was divided by a septum that this woman was born with.
And so you actually fixed this and made it look like the first one.
Correct. It became a normal uterus. We took out the divider in the uterus, and the shape of the uterus was normal, just like any.
And could this patient have a better chance of being able to get pregnant because of that?
Actually, she'll have a better chance of carrying a pregnancy rather than miscarrying. Miscarriage is the most common event in terms of pregnancy that happens with a septate uterus.
Great. Now, some of the other things I want to talk about, what are some of the factors that people can associate with possible infertility? If I'm concerned about it, what things should I be looking at as a possible factor for infertility?
Okay. Well, 40% of couples with infertility have a male factor issue. So sperm quality, sperm function is a very important thing to look at. And it used to be thought that the guys were always fine and it was always the woman's fault. Well, of course, that's not true, and male factor plays a significant role. For women, we look at ovulation is probably the biggest problem for women, ovulatory difficulties, lack of ovulation, problems with ovulation. And then, of course, then there's anatomic structural problems, problems with the uterus or the fallopian tube or somewhere in the pelvis.
Now I want to take a step back here. Ovulation means release of an egg. Not everybody knows what that means. We're talking about release of an egg. And the other thing I think is so important, I want to address it here, that one of the problems with infertility is so many people want to find the blame. It's the man's fault, it's the woman's fault. There is no blame here. I mean, I try to tell my patients this is a very difficult situation no matter how you look at it. And I try to tell my patients there is no blame in either direction. This is just something that we need to address. What do you say to those patients that come in and say, well, I feel like it's all my fault or it's all my husband's fault? How do y'all address that?
Well, I tell them, of course, they're not going to have a baby without both of them. I mean, this is a couple's problem. This is a couple's issue. It's not an individual issue. Of course, we're like detectives and we try to find out where the problem is and hopefully have a fix for it so we can allow the couple to achieve a pregnancy. But some people do blame themselves, and that's a difficult issue to work with. And
that's one of the things that in my patients I really do try very hard is to take that whole idea of they've done something. This is a natural process, and it's not something that you've done that has caused this problem. It's just something that in nature has occurred, and luckily now we have something that can address it. Do you agree?
Oh, yeah, quite definitely.
Now, the other thing I want to talk about, because you mentioned a little bit earlier, age can be a big factor in this. Describe to me a little bit about some of the things that can be important as far as age, and do you offer patients different options based on age?
Well, just naturally, as women get older, their fertility declines. So we become more aggressive in evaluating and treating couples when the woman is of a more advanced reproductive age.
Okay.
And that's just a basic sense that we use to approach couples.
Now, we've had a great discussion about some of the causes of infertility. We'll be right back after these messages, and we're going to talk about some of the medical treatments of infertility. We'll see you right back after these messages. Welcome back to Helping Today's Woman. Tonight we're discussing infertility with Dr. Glen Weitzman, reproductive endocrinology and infertility specialist at Nashville Fertility Centers. In our first segment, we talked about some of the causes of infertility. In this segment, I want to take a turn and start talking about some of the medical treatments of infertility. So Glen, I want to kind of start off this discussion with where do we begin as far as, we've talked about when patients need to seek care or at least seek counseling. When do they need to start seeking treatment for infertility?
Well, after a consultation with the woman's doctor, the doctor will usually decide or try to find out what the basic problem is. And then it all depends on what the basic problem is, where they go from there. Sometimes in 10 to 15% of couples, no problem is found. So it may just be more time, it may be empiric treatment. Then there are ovulation issues, anatomic issues, and male factor issues, and we address them a little bit differently.
Okay. Now, one of the things I know that I do oftentimes is I've talking to patients is we tend to move them pretty quickly to something called Clomid or a medication called clomiphene citrate. Can you describe to us a little bit about what this is and what's involved in this medication?
Yeah. Clomiphene citrate, or the brand name Clomid, is an oral medication. It's an ovulation induction agent or maybe an ovulation enhancement agent if the woman is already ovulating, or we believe she's already ovulating. And it's usually taken for 5 days in the first part of the cycle, only for 5 days, and then approximately a week after the last day of Clomid therapy, ovulation will occur if it's going to occur on that medication.
And we have pretty good success with this, but are there complications associated with this medication?
Well, women can have side effects while they're taking the medication, hot flashes, dizziness, blurred vision, sleep disturbances, sort of menopausal type symptoms, but they're usually just a few days around the time she's taking the medication. And in terms of complications from the therapy, we usually think about twins or multiple pregnancy rate, which is between 8 and 10% of pregnancies conceived with Clomid or more than one, the great majority of which are twins.
Right.
And outside of that, there's no real harm with the taking of Clomid.
And one of the things I think people need to understand about Clomid, because everybody wants Clomid's success rate to be pregnancy. Unfortunately, that's not Clomid's success rate. Clomid's success rate is based on ovulation and the chance to get pregnant. Is that correct?
Correct.
And that's one of the big things, because I think patients say, well, if one pill works, 2 pills will probably work better because I ovulated but I didn't get pregnant. What do you say to that patient?
Well, We sometimes dose Clomid based on the woman's weight. So sometimes we'll even start on 2 tablets. But if a woman's of a normal size, we'll typically start with 1. And if it's not effective, we'll move up to 2, meaning if it doesn't result in ovulation, we'll increase the dose. Now, Clomid, as I say, can give with one hand and take with the other. Clomid can thin the endometrial lining, perhaps make it less receptive to implantation of the embryo, and there may be more side effects, as I mentioned before, with a higher dose of clomiphene. So we try to give the amount that will help us achieve ovulation and not more than that.
Now, interestingly enough, you mentioned the thinning of the lining, because oftentimes I've heard when we do have a thinning of the lining, there's another medication that sometimes we use, and that's called Femara. Okay? Tell us a little bit about that medication.
Well, Femara has been used to prevent the recurrence of breast cancer in women who've had breast cancer because of what it does hormonally. And because of what it does hormonally, we can use it to induce ovulation. It is more friendly to the lining of the uterus. It does not thin it, and we believe, therefore, it may be more receptive to a pregnancy, a week after ovulation occurs when implantation occurs. So we'll sometimes use it as an alternative to Clomid as an oral medication that's easy to use and relatively inexpensive.
And that I understand has a less incidence of twins also because of its mechanism of action. Is that correct?
The multiple rate is somewhat lower than clomiphene, correct.
And it's used pretty often now. It's being used more and more commonly, isn't it?
More and more commonly. I don't think it's quite overtaken Clomid as an initial first-line therapy, but it may in the near future. It's very popular.
Now, there's another line in the chain. We've tried Clomid, and Clomid hasn't worked for ovulation. We've tried Femara, and Femara hasn't worked. That's pretty much where I'm at my max. Well, I tell people I will pretty much go to Clomid, but I won't go past that, Clomid or Femara. Then we start getting into injectable medications. Tell us a little bit about that next step and kind of what some of the complications are with that therapy.
Well, the injectables are actually a purification of the same hormone that the pituitary gland, the pituitary sits right under the brain, that the pituitary uses to stimulate the ovaries to ovulate. It's just in a concentrated form, and it has to be given via injection to get into the body and to be effective. They're more expensive. The side effects, the menopausal side effects don't exist, but there are higher complication rates with it. There's a higher multiple gestation rate, which is about 15%. And then there are the risks of what's called ovarian hyperstimulation syndrome if the ovaries are overstimulated from the injectable medications.
And that's the reason I don't give it, is because of the concern about ovarian hyperstimulation syndrome. But there's also the problem with multiple pregnancies, is that correct? And that is a very real complication associated with these medications, isn't it?
That's correct. If you ever see someone who has quintuplets or septuplets, it's likely that they achieved pregnancy with the injectable ovulation agents. Whereas I mentioned with the Clomid or Femara, the multiple rates are lower, and it's typically just twins. Now, it's not typical that you get septuplets with injectables, but when it does occur, rarely, it's usually with those medications.
And one of the things I think is so important is a lot of people don't understand. If you haven't ever been through this, I mean, you've been through a lot. You've gone all the way to injectables to try and get pregnant. Then all of a sudden you see, okay, I've got a number of eggs this time, and it's a hard line to play, isn't it?
Oh, very. You know, people spend a lot of money. They invest their hopes and their dreams, and if we're using the injectable medications, we'll do monitoring with ultrasound. So just before we trigger ovulation, we may see 3 or 4 or 5 eggs, and we either make a medical decision that we're not going to complete the cycle because the risks of multiples or high order multiples are too high, or we may give the patient the option, and usually the patients want to complete the cycle and take their chances because they so desperately want to get pregnant and not give up the chance they have that particular cycle.
I want to come back to that when we come back after these messages. We're going to talk a little bit more about some of the more exotic ways to get pregnant, measurably IVF. We'll be right back after these messages. Welcome back to Health in Today's Woman. Tonight we've been discussing infertility. In our first segment we talked about some of the causes of infertility. In our last segment we talked about some of the medical treatments for infertility. In this segment I want to take a little bit more of an approach to some of the more aggressive opportunities for pregnancy, namely IVF, or in vitro fertilization. Now, to help me do this, I've had Dr. Glen Weitzman, who joins me again. And Glen, I want to kind of start with this, with kind of the historical background, because it's amazing how we've gotten here. It's been the last several years that the test tube baby that came out of England has actually graduated from college. So it hasn't been that long that we've actually been able to do this in vitro fertilization, or what people used to call the test tube baby. Tell us a little bit about how we've gotten here and what the history is behind this.
Well, the first baby born through the IVF technology was in England in 1978, and in the United States it wasn't until 1981 that a pregnancy was achieved through the IVF process.
Wow.
And that was in Norfolk, Virginia. And then when it was successful, it just spread out throughout the rest of the country. Many programs have evolved. Every major city pretty much has an IVF program. And there are approximately 70 to 80,000 cycles of in vitro completed per year in the United States.
And I have to say here, this is such a great opportunity, because being a parent is such a wonderful opportunity, and we're giving people who once were told there was no options, we're giving them options, and that is just an amazing thing. And I may be biased, but I think it's one of the most amazing things we've done in modern science, is the whole idea of IVF. Can you give us a little bit better basic understanding of what is involved in IVF?
Well, we use injectable medications to stimulate the woman's ovaries to produce several mature eggs in that particular cycle. We monitor the process carefully. We remove the eggs from the ovaries through a minor surgical procedure. In the laboratory, we mix the eggs and the sperm together to create the embryos, and then typically select 2 embryos to be placed back into the woman's uterus, and we cross our fingers and we hope that the pregnancy test is positive about 10 days later.
Now, is everybody a good candidate for this?
Not everybody's a good candidate for this. You know, we need to have eggs, we need to have sperm, and we need to have a nice place to put the embryos in, a good uterus, a good healthy uterus to put the embryos in.
Now, we're lucky here, because we're going to show you some pictures, some amazing pictures that we have here of actually, we're going to start off here, and this is just an actual human egg, is that correct?
That's correct.
So you kind of see what it looks like. Then as we progress on, this is a fertilized egg. So this was actually done in the laboratory.
This is the day after the sperm and egg met. This is what we see as a fertilized egg.
And then the next picture, of course, is the embryo. And this is what will be reimplanted into the uterus. Is that correct?
Correct. This is the embryo, what we call the blastocyst stage, 5 days after fertilization. And 1 or 2 of these will be placed back into the uterus with the hopes that pregnancy will be achieved.
And that is just amazing that we start there and end up with, you know, our 7-year-old children. It's an amazing opportunity. It's an amazing science.
That's right.
Now, let me kind of take a little bit of a step here on a different direction. We talked about not everything is female infertility. Some of it's male infertility. And one of the things that is able to be addressed now with IVF is male infertility. Describe to me how y'all are addressing male infertility using IVF.
Correct. In the early 1990s, scientists in Europe developed a procedure called ICSI, or intracytoplasmic sperm injection. And that's where we take a single mature egg and we inject into that egg a single live healthy sperm to help the sperm fertilize the egg. So we can now have 1 good sperm for each good egg that we retrieve to achieve fertilization. So sperm counts can be exceedingly low. And in fact, we can even do this with sperm that's extracted directly from the testes itself.
It's amazing. So we actually, a lot of patients just were basically no luck. Now through ICSI, even with male factor infertility, really do have fairly significant chances to get pregnant, don't they?
They do. ICSI was a revolution in the treatment of male factor infertility.
Now, the next thing I want to talk about is something that some patients deal with, and that is the whole idea of donor egg. And that's where maybe the patient is older and does not have good eggs, or just maybe they just don't have good eggs for whatever reason. Tell us a little bit about this process. And do y'all offer this at Nashville Fertility Center?
We do. We recruit our own egg donors. We screen them very thoroughly. They go through a long process to be potential egg donors. And then when they're selected by a couple to be their egg donor, we stimulate the donor, retrieve her eggs, typically mix with the husband's sperm to create the embryos, and the recipient woman's uterus is prepared to receive the embryos at the end of that process.
So this is something, and who's a good candidate for this patient, for this particular procedure?
Well, typically a woman who's of advanced reproductive age, who doesn't have any eggs left, or her eggs are not helping her achieve pregnancy. We sometimes have women who have premature menopause, even in their 20s, women who are treated with chemotherapy agents for a cancer that they're cured from, but the chemotherapy destroyed their eggs and they still want to have a family. So there's a lot of women who are good candidates for this technology.
It's amazing where we've come, because that's, this is a big deal, especially to those patients who are dealing with chemotherapy and other things that we're told that their chances of fertility were completely gone. I mean, it's an amazing feat that we've gotten this far to be able to help those patients. But we'll be right back after these messages. And if you look on our screen, we've got one of Dr. Weitzman's cards to explain to you a little bit about how to get in touch with him. We'll be right back after these messages. Welcome back to Helping Today's Woman. Tonight we've had a great discussion about infertility with Dr. Glen Weitzman of the Nashville Fertility Centers here in Nashville, Tennessee. This can be a topic that can be very emotional and difficult for those that are dealing with it. The amazing thing is that we now have opportunities and technologies that can help these patients achieve pregnancy. We hope you've not only gained some answers from our show tonight, we hope you've gained some encouragement, because I know that this can be a very difficult topic and something that a lot of women do have to deal with. We thank you for joining us tonight. We will see you next week. Thank you and good night.